maternal fetal medicine actually replaced the term with different categories like early term, full term, late term, and post term. The question was, what was full term? So the answer to this is C, 39/0/7 to 46/7. This is the actual definition of full term. So let's see. If you see this chart, here we can see the definition of preterm is definitely less than 37 weeks. Anything less than 34 weeks is a late preterm. Initially, we thought 30 to 42 weeks, 37 to 42 weeks is term, but that has been categorized as different categories now. 39/0/7 to 46/7 is a full term now. This gap is early term, and this is late term. Whatever happens after 42 weeks is post term. So these are different categorization. And to emphasize that the deliveries should happen between 39 to 41 weeks. That is the ideal time to deliver. This is the 2013 ACOG recommendation, and after that, the whole definition is changed. Moving on to question number 2, Sankalp will take that.
The question was, what is the predominant method of heat loss in a newborn when nursed in an incubator? So there are all these 4 mechanisms mechanisms of heat loss for a baby after delivery in an incubator or warmer. But if you keep a baby in an incubator, convective heat losses are taken care of because the air currents are not flowing. Conductive heat losses are taken care of because the baby is on a warm surface. Since we provide humidification, evaporative heat loss is also taken care of. So predominantly the baby loses heat by radiation in a incubator, because evaporative heat loss, conductive and convective, all 3 are taken care of.
Even to reduce radiative heat losses, you can have double wall incubator. That also reduces radiative heat losses. Single wall incubator, radiative heat losses are more. Question number 3. So which of the following are the new changes in ICROP 3 in 2021? American Society of Ophthalmologists actually came up with a new classification of ICROP, and options were notch term, regression, reactivation, all of the above. All the 3 terms which ABC are the new entries into the classification of ROP. Let's see. So answer is D, all of the above. Let's see the classification. The zone 3+, plus, and the various stages are almost as it was in the previous classification. Aggressive ROPs was already there. What is new is regression, where they've not defined earlier the regression term, but now they've come up with a regression. Reactivation, where probably after the treatment, where we see re-evaluate the eyes and they see whether the ROP is reactivated, and again we make treatment or not. Notch is a term which is describing incursion of ROP lesion of 1 to 2 into a more posterior zone. There is a new term, but there is ophthalmologist writing. There is a notch, and it is usually it's seen in the posterior zone of retina, not in the anterior zone. And there's a very small notch, 1 to 2 clock hours. So these are the 3 terms included in the ICROP 3 2021 classification. Question number 4.
As per NRP 2020, delayed cord clamping has been recommended for all preterm babies for more than 30 seconds if they do not require resuscitation. What is the class of recommendation and level of evidence of this recommendation? So basically, level of evidence. So one should remember level of evidence and class of recommendation for all major, recommendations, especially for NRP. So basically, we decide the level of evidence based on what quality of evidence is available for a recommendation. Like if it is a meta-analysis or high quality RCTs, it is level A. If moderate quality RCTs are available, it is level B or level 2. And if lower quality of evidence is available, so it is level C and level CLD and level C EO, so on. So level or quality of evidence depends mainly on the amount of evidence that is available. However, strength of recommendation depends on both quality of evidence and other factors like how feasible is the intervention, what is the cost involved, right? And how much is the impact factor, how much is the, it is not just the certainty of evidence, right? What is the strength, how much is the number needed to treat, what is the cost. So based on all of that, we decide whether how strongly do we recommend this uh, intervention, right? So based on that, the delayed cord clamping, it is recommended that it is the strength of recommendation is moderate, and level of evidence is moderate, and strength of recommendation is 2, right?
So answer here is D, class 2A, and level of evidence.
Level of evidence
B.
B.
B. So moving on to question number 5, which of the following growth charts includes Indian data? So Fenton 2013, Intergrowth 21st, Bepson and Benda, and Lubchenko. If you have any idea of the current growth charts, Intergrowth is the latest one, out of which Indian Center in Nagpur is the one which included pregnant women and postnatal babies also. So this is the answer, Intergrowth 21st. And Intergrowth 21st included multi-ethnic population, predominantly from Brazil, Italy, Oman, UK, USA, China, India. Nagpur is the center. And this included predominantly 33 to 37 weeks, almost, although we have data of less than 33 weeks also. Talking about other charts, Fenton chart is not a study, it's a systematic review of various growth charts. 2013 was the latest one, and it was gender specific, boys and girls. Intergrowth 21st also was gender specific. Bepson and Benda was the older chart used in US, but predominantly Fenton is one used currently, but it is a systematic review and not a primary study. Intergrowth 21 is a primary study conducted in various countries, out of which India is one of the centers.
The next question is, recognized benefits of breastfeeding are all except. So we know that breastfeeding reduces the risk of allergy, it reduces the risk of NEC, it reduces the risk of viral gastroenteritis and other infections in infancy, right? So first 3 options are obviously there. It does not reduce the risk of hemorrhagic disease of newborn, and therefore it is recommended that all babies get vitamin K immediately after birth, right? So we know that breast milk is not a good source of vitamin K, and therefore D is the answer.
Question number 7. All are the components of suspected triple I except. So here, triple I is the term, previously we used to say it's chorioamnitis, but 2015 NICSD recommended to change the term to triple I, and triple I stands for infection, inflammation, or both. So 3 I's: intrauterine inflammation, infection, or both. So out of which there are various terms, we'll go through it. Choices were baseline fetal tachycardia more than 160, maternal WBC TLC of more than 15,000, definitive purulent fluid from cervical or, and positive amniotic fluid gram stain or low glucose or WBC count of amniotic fluid. So answer is D. This is the criteria for triple I proposed by NICSD in 2015. So maternal fever is a must of more than 39 degrees, or any one occasion is a major component of triple I. There are 2 definitions here: suspected triple I and confirmed triple I. Suspected triple I, what are the choices? We had A, B, C: fetal tachycardia, maternal TLC high, and definitive purulent fluid. The 4th choice was a category of confirmed triple I, where we have biochemical or histopathologic evidence of inflammation or infection, either in the placenta or membranes or amniotic fluid. So when you have positive biochemical or histopathologic evidence of inflammation intrauterine, that you diagnose it confirmed triple I rather than suspected triple I.
Gopal sir, there is a question. Dr. Mayur has asked, what is the full form of triple I?
Yeah. So intrauterine infection, inflammation, or both. So either inflammation or infection, or either inflammation or both might be there. So triple I is 3 I's.
Okay.
So basically it is similar to what we label for sepsis. Suspected sepsis when there are symptoms of sepsis,
Yeah.
confirmed sepsis when there is a culture proven evidence, right? So something like that.
Yeah. Previously it was a more of an ambiguous term of chorioamnitis, but it was ill-defined. So NICSD came up with a categorical definition of suspected and confirmed triple I.
So next question is daily supplementation is not required. Which vitamin is not required for neonatal cholestasis? So we know that vitamin E, being a fat soluble vitamin, supplementation is required. Zinc supplementation, all guidelines recommend. All guidelines also recommend that water soluble vitamins should be given in double doses for neonatal cholestasis, right? So answer is iron, and mostly because iron is absorbed in the duodenum, right? And therefore by that, the bile and liver enzymes, they don't play any role in iron absorption, and therefore iron supplementation routinely is not required in neonatal cholestasis. Rest all vitamin supplements and zinc supplements are required.
Question number 9 is also a picture question. So there's an X-ray where even if seeing an X-ray, you can suspect a heart disease. So you have a wall-to-wall cardiomegaly, or what is called a box-shaped heart. This is the classical abscess anomaly, where there was already a hint towards abscess anomaly, where you have a very large RA, and the tricuspid valve, particularly the septal leaflet, is displaced towards the right ventricle. So functional right ventricle capacity is very less, and blood flow actually goes from right atrium to left atrium through the ASC. So this is one of the cyanotic congenital heart disease which can present at birth, and with large RA, with small RV, probably you are dealing with abscess anomaly anytime. So the choices were almost, there was no mismatch. Propranolol and TOF can happen. SSRIs can be the cause of PPHN. All were correct, but the picture X-ray and the figure shown was matching with abscess anomaly. So the tricuspid valve, normally this is the picture, and in the abscess anomaly there is a huge RA, and abscess the tricuspid always displaced into the RV, and the RV is practically a very small ventricle, and it doesn't function properly, and blood flow through it. And luckily we have an abscess anomaly at our center currently.
Next question is, which of the following statements is true for fetal circulation? 100% of cardiac output goes to the lungs via pulmonary artery. So in fetus, we know that from the right ventricle, blood goes to the pulmonary artery, but it does not go into the lung. From the ductus, it is shunted right to left to the aorta. So this statement is false, that blood goes to the lung. This is wrong. Next, the arterial ductus arteriosus helps. What was the second option? Sorry. The ductus helps send oxygenated blood to the brain. This is also false, because ductus helps the blood transfer from the right pulmonary artery to the aorta, right? It causes from right to left shunt, right?
Yeah.
And umbilical vein, third option is umbilical vein carries oxygenated blood. This is true because blood exchange happens in the placenta, and umbilical vein carries oxygenated blood from the placenta to the baby. Via ductus venosus, it reaches the IVC and then the right side of the heart. And option D was foramen ovale typically closes by 36 weeks of gestation. Foramen ovale is often open at birth, and it closes sometimes after birth, right? So this option is also
functionally it closes by 24 hours.
By 24 hours.
Yeah. So option C is the correct answer here, and we should know this fetal circulation thoroughly, because that helps in various management of postnatal transition and PPHN. Question number 11. All are management of persistent hypoglycemia, except this was a slightly tricky question. So all the drugs are used. Glucagon is not commonly used for persistent hypoglycemia, but usually for refractory hypoglycemia. But yes, if given a choice, I would choose answer D. All the doses are correct. The mode of administration is wrong. Glucagon is never given IV. It's given either subcutaneously or IM. So though the choices, the answer is D here, glucagon IV. That is the wrong choice. So if you see, if a baby is requiring GIR of more than 12 mg per kg per minute, usually for more than 7 days, it's called persistent. And drugs commonly as hydrocortisone 5 mg per kg per day to divide this. Digoxide is 10 to 20 mg per kg per day, usually orally. Glucagon, usually SC or subcutaneous or IM, never IV. Octreotide, 20 to 10. It's a wide range, but normally normal dosage is 2 to 10 micrograms per kg per day, usually subcutaneous. So answer correct option was answer D, glucagon, because it was mentioned IV there.
Then the next question is, most common anomaly associated with single umbilical artery is. So it is renal anomalies. So although all of these are associated with single umbilical artery, but around 7 to 8% of all children, all babies with single umbilical artery have associated renal anomalies. Okay, so cardiac anomalies are also associated, but the incidence is less, right? So some guidelines, they recommend doing an ultrasound KUB for all babies with single umbilical artery. However, it is controversial because the yield is not too much, right? So the doing an ultrasound would be controversial for all babies with single umbilical artery, but yes, among all the abnormalities possible, renal anomalies are the most common ones associated with single umbilical artery.
Question number 13, standard guidelines for reporting of meta-analysis of RCTs, which is the guideline you choose, Consort, Quadus, Prisma, and Moon. So there are various guidelines given how to report studies for RCTs or meta-analysis or epidemiological studies, diagnostic studies. There are various guidelines where we need to see to cross-check whether the methodology and the results are correct or not. So for critical appraisal, there are various guidelines. So out of this, for meta-analysis of RCTs, the one uses Prisma. So let's see. So Consort is consolidated standards of reporting trials usually used in RCTs. This is the Consort is used in RCTs. Quadus is usually used in diagnostic accuracy studies, quality assessment of diagnostic accuracy studies. Prisma is the one of the question asked here, preferred reporting items for systematic reviews and meta-analysis. The last one, MOOS, is usually used for observational studies, meta-analysis of observational studies. So these are the standard guidelines used, and one should at least know which guideline is commonly used in this study.
Next question is, surgical closure of PD is indicated in all except. So basically this question means that if you have a baby with symptomatic hemodynamically significant PDA, what would be the indications where you cannot do a medical management? So surgical closure is usually done when you cannot do a medical management. So if you look at option B, C, and D, all three are contraindications to medical management, and there are reasons for surgery. Like if the baby is more than 3 weeks old, if the baby is having oliguria or deranged creatinine, then you can't go for medical management. Or if the baby has already IVH grade 3 or 4 or progressive IVH, then you can't go for medical management. So B, C, and D, all three are indications for surgical management of a symptomatic PDA. Option A, failure of 4 courses of medical therapy. This is wrong because generally we give just 2 courses of medical therapy. And if that fails, then we immediately consider surgical closure in case of symptomatic PDAs, right? So option A is wrong. B, C, D, all three are indications for surgical closure of symptomatic PDA.
So this is slightly tricky question actually. So probably most of you might have confused, but more than 2 courses of medical therapy is an indication surgical closure, not 4 courses. Don't give 4 courses. Okay. So let's move to the next one. Answer is A here. So this was again a picture question. So the pattern of inheritance here was various options were given. Answer is option D, mitochondrial inheritance. Because if you see, all the affected persons were inheriting genes from the mother side. Because father was not affected, all the genes were through mother side. And once the father male is affected, there was no inheritance down the line, next generation. But once female is affected, the next generation is affected. So this is classical of mitochondrial inheritance. So few examples of that will be Leber's optic atrophy, more of
Murph, Melas,
Mela's, Murph, all this fall into mitochondrial inheritance pattern. So this is the classical one. If only the male is the female is a source for next generation inheritance, and male next generation, if a male is affected and the next generation is not affected, you're dealing probably with the mitochondrial inheritance.
Next question is, all are true about undescended testes except. So option A is 5% of boys are born with undescended testes. This is true, right? Second, patients with undescended testes require more extensive workup to rule out CAH and DST. Of course, if you have undescended testes, except especially a bilateral undescended testes, then you should definitely rule out CAH and DST. You should look at the penis properly. If there is micropenis or hypospadias, then you should even be more extensive about your workup for CAH and DST, right? So all babies with undescended testes, especially bilateral, should require workup for CAH and DST. So option B is also true. Then option C, about 10% of males who undergo surgical correction experience residual infertility later in life. This is wrong. If the surgical correction is done timely, before 6 to 9 months of age, there is the future risk of residual infertility is minimal, right? So this is false. Risk of testicular cancer is equal in descended or undescended testes. Yes, if a baby has unilateral undescended testes, the risk of cancer is equal in both the testes which is undescended and the testes which is descended. This is because it is said that there are certain factors which are produced in undescended testes and which are predisposing the baby to undescended testes. And since these are genetic factors and these are same for both the testes, so risk of cancer is equal in both the testes, descended versus undescended, right? So option C is not true. Rest all are true.
But definitely you need to operate and know the timeline. 6 months is the timeline when you should send the referral to a surgeon and get it corrected.
Yes.
So answer is question number C, it's wrong. So question number 17, again a picture question, X-ray, day 3 of life, a preterm probably, and the classical, this is a classical PIE picture, pulmonary, interstitial and emphysema. CDH is not there because the diaphragms are intact. BPD definitely at day 3 of life, we don't diagnose BPD. Pneumothorax, there is no evidence of air leak, although PIE itself is a form of air leak. So in PIE, we see classical honeycombing. It might be unilateral sometimes. And there will be small coarse densities which will highlight from the hilar to the periphery. The classical PIE changes are seen in this picture. Definitely the course of the baby also needs to be considered to diagnose PIE. So PIE are usually cystic or sometimes usually cystic or linear. They can be, both can be seen. Their coarse non-branching translucencies from hilar to periphery. And definitely a classical honeycombing can be seen. And this is more of, moment you see a PI, you cannot miss it.
Let's identify the abnormality in this loop. This is a flow time. Actually, it's a scalar, not a loop. So that's a typo. So it's a flow time scalar. And we can see that in the expiration, instead of the dotted line where the expiration touches the 0 line at the end of expiration, there the solid line is not touching 0. There is some residual expiratory flow and the expiration abruptly ends and inspiration starts. So this leads to air trapping. The baby is not able to expire completely. Baby is still expiring and the ventilator has delivered another breath. So if you see a expiration which is not finishing and not touching 0 and inspiration starting, this is a typical of air trapping. Treatment would, which this air trapping can lead to hyperinflation and subsequently possible air leak, right? And treatment would be to give a proper TE, give a proper time for the baby to expire, increase the TE by reducing the rates or by reducing TI, give adequate TE.
The next was all of the following are associated with hypercalcemia except. So Williams syndrome is classically associated with hypercalcemia. Hypercalcemia can itself cause subcutaneous fat necrosis and there is association with it. primary hyperparathyroidism is one of the commonest, although rare, but one of the commonest causes of hypercalcemia. The fourth option was familial hypercalciuric hypercalcemia. The actual cause of this is hypocalciuric hypercalcemia. So there is a condition called familial hypocalciuric hypercalcemia that causes hypercalcemia. So there is a word play there. So hyperparathyroidism, hypocalciuric hypercalcemia can cause hypercalcemia. One of the medications, thiazide, sometimes causes hypercalcemia. And there are miscellaneous causes which you can look into. Most common is iatrogenic.
So newborn term male infant. So I'll just read it briefly. This is a term infant. You all have read this question. Who has thrombocytopenia, and mother is a case of chronic ITP, right? And the mother's platelets are now normal, but the baby has ITP. Baby has low platelets, right? So of course the confusion is between neonatal autoimmune and alloimmune thrombocytopenia. So whenever you have a baby with thrombocytopenia, isolated thrombocytopenia, the baby is otherwise well, right? You should think of immune thrombocytopenia if the baby is overall well. If there's a history of thrombocytopenia in the mother, then it is autoimmune thrombocytopenia because antibodies from the mother have gotten transferred to the baby. If there is no history of ITP in the mother, then think of alloimmune thrombocytopenia, that the baby has made antibodies against father's antigen, and which are causing causing thrombocytopenia, right? So whenever there is isolated thrombocytopenia, baby is overall well, think of immune thrombocytopenia, autoimmune if mother has ITP, alloimmune if mother does not have ITP.
So answer is neonatal autoimmune thrombocytopenia, antibody against mother's platelets. Question number 21. High position of UAC corresponds to which vertebra? So high is T6 to T9. Answer is C. So if you see the X-ray, this is the UBC and this is the UAC which loops down and goes up. So anything between L3 to L4, lower down close to the kidneys, the low position UAC, and high position is T6 to T9. So one should not go beyond T5, and classically we should avoid T12 to L2 because there you have origin of major organs like kidneys involved. So ideal position is T6 to T9, higher UAC is preferred.
The initial FiO2 for resuscitation of preterm neonates, it is, we all know, and you should not have any doubts about this. It is 21 to 30%, right? And if you're resuscitating a baby, full-term baby or a late preterm baby more than 35 weeks, it is 21%. I think, Dr. Gopal, the number of participants have started reducing because time it's getting late. We should get fast.
So grade the degree of IVH here. So this is classically grade 3 IVH where there is the interventricular hemorrhage with some dilatation of the ventricle. If you don't have dilatation and less than 50% is occupied, that is grade 2. Because you see a dilatation here, so it's classically grade 3 IVH. So answer here is grade 3. And this is the Volpes grading, grade 1, 2, 3, 4. We should all know and not go into all this stuff. Question number 24.
Neuroimaging that detects HI earliest is diffusion weighted MRI. So in diffusion weighted MRI, typically the HI seen is on day 3, day 7 of life, right? And we get MRI done in that period. After day 7, there is so-called pseudo-normalization between after day 7. So one should try to get HI, all moderate to severe HI. If you want to get MRI done, get it between day 3 to day 7 of life, and definitely ask for a diffusion weighted MRI. Right, so we see so-called diffusion restriction, and here it is seen in the posterior limb of internal capsule. Right, so there is these hypodense, these areas.
Reflex sign is classical of early identification of severe significant asphyxia. So question number 25, Hipster trial is related to which of this? Answer is use of HHFNC as primary mode of respiratory support. This was published in NEJM, and they showed that there was increased treatment failure if high flow was used as a primary mode compared to CPAP. And after that, the usage of high flow has actually come down as a primary mode in preterms. So rest all well. Timing of delivery in FGR with abnormal Dopplers is a truffle study. Platelet transfusion threshold is Planet 2 and incremental milk feeding rate is SIFT trial.
Development of CPAM occurs in which phase of lung development? So basically, lung undergoes various stages of embryonic, pseudoglandular, saccular, and canalicular. So I think it is pseudoglandular where the CPAM occurs. Can you show the next slide?
Yeah.
Yeah. So I think it is pseudoglandular where the on the second stage of lung development, if some abnormal development happens, it leads to CPAM. If there is abnormal development in later stages, then various, can you show the next slides? So if the saccules and alveoli are not formed, then it is pulmonary hypoplasia. And in the earlier stages, if the lung development does not happen in the first stage, embryonic, it is pulmonary agenesis itself, right? So this you should remember the stages of lung development. And if abnormal development happens in any stage, what disease can possibly it lead to? Right? So pulmonary hypoplasia usually occurs late. Pulmonary agenesis in the first, and midway pseudoglandular CPAM can happen.
So 37-weeker with 2.8 kilo birth weight was delivered by LSCS, developed respiratory distress, and was intubated and put on HFO. MAP of 20, FI2 of 100. And here PO2 was 40. Calculate OI. The answer is 50 years, although we rarely see OI of 50. Let's see how we calculate that. OI is MAP into FiO2 by PO2. So MAP here is 20 into FiO2. So 2000 divided by 40 PO2. The answer is 50 years. So OI should be calculated in any baby who is ventilated. And worsening or improvement of respiration can be diagnosed by calculating OI.
So what is the current neonatal mortality rate in India? Answer is 22 based on the latest Ministry of Health data in 2019. Right. So whenever the fellows are giving exams, I would request that they should be aware of the current neonatal mortality, infant and under 5 mortality based on the latest data from MOHFW or NFHS.
What is the correct dose of antenatal steroids? Again, there was confusion. The choices were different, almost confusing statements. So dexamethasone 12 mg 24 hourly for 2 doses, that's not routinely given. Betamethasone 12 mg 12 hourly, again not given. Dexamethasone 6 mg 12 hourly for 4 doses. This is what is recommended. Betamethasone answer D also is wrong. So answer C is dexamethasone 6 mg 12 hourly for 4 doses. And currently, dexamethasone is the drug of choice for developing countries, particularly India, where the correct betamethasone salts are not available. So, Government of India recommends dexamethasone as a drug of choice for antenatal.
How does milrinone act? It inhibits phosphodiesterase 3 enzyme, which causes increased cyclic AMP, right? And which causes increased contractility in the heart. Similar drug sildenafil inhibits phosphodiesterase 5, increases cyclic GMP, which causes vasodilation, right? So milrinone phosphodiesterase 3 and sildenafil inhibits phosphodiesterase 5.
So in this video, classically you can see this is the PDA, this is the ductal view, where you see the tripod sign, where this is the RPA, this is the left pulmonary artery, and this is the PDA. Here you see mixed color, rainbow colored PDA, where there is orange and blue mixed color is there. So this is classical of bidirectional PDA. In left to right flow, you will see more of red color jet. Coaptation is not there. Here we are not seeing the arch. TR jet is not seen here because we are not seeing the correct view. So this is bidirectional flow in ductus artery. So this is the classical tripod position to see the ductus.
Mission Vatsalya of Government of India relates to. Answer is Child Protection Services. It is a program by Government of India. For next slide, please. Next. Which supports and sustains children in difficult circumstances, and it provides context-based solutions for holistic development of children from difficult and varied backgrounds. So basically, those who are underprivileged, those who are in some form of dangerous or some where parents are not able to cope up and provide to the needs of the baby, then the government pitches in and provides support to such children. So this mission is called Mission Vatsalya.
So next question is regarding breastfeeding. This is my favorite question. So I repeated this question from the last session. What is this position of feeding? And we can see classically this is a double football. Let's see if we have other options. Yes, we have the football and cradle where both the babies are actually placed parallelly. Double football, they are placed almost vertically facing each other. This is the front cross where the babies cross each other, and sometimes mothers can feed an upright latch also. So these are the various feeding. Even in breastfeeding mothers, we should advise in twins also that they can exclusively breastfeed, and they can use this method when both the babies demand simultaneously.
So as per India Newborn Action Plan, single digit NMR, we saw that current NMR is 22. But what is our target? Till when do we want the NMR to reduce to less than 10? The target of this program is till 2035, option C. So the government targets that by 2035, they want the NMR to reduce by to less than 10.
Yeah. So all the states to individually target this by 2035. So answer is 2035. We are not 2030. So question number 35, preterm 27 plus 4 weeker, 940 grammer. Now almost 2 months of life is on high flow, 3 liters and FiO2 to 25%. Grade the severity, and you see the X-ray here. Classically, there is haziness and some densities around the, not bilateral, but yes, some densities in both the lungs. This is, if you know the current classification, it's almost falling into a grade 2 BPD. Let's see. So if you see NICSD 2018 revised the classification, currently we're using this. Mild grade, high flow, less than 3 with FiO2 of 25 is grade 1. In our baby, it was at exactly 3 where it falls into grade moderate BPD, where more than equals to 3 liters with FiO2 of 22 to 29. So this is the classification used in NICSD, and all the fellows should actually go through this and should know what is the current definition of BPD.
So red reflex we all do after delivery for all babies, right? To rule out various eye pathologies, right? So at what distance should we project light from? So answer is 18 inches, which is approximately 45 centimeter, right? So we know that if the reflex is red in both the eyes, it is normal. If it is whitish in one eye, it may mean congenital cataract or maybe some other eye pathology. So one should do this red reflex in every baby and before discharge, right? And the distance from which you project is 18 inches.
So this is standard of care, and also you are legally responsible if you miss red reflex. Because once you have seen a newborn, you are supposed to see the red reflex, and that's the standard now. So question number 37 related to CDH. All are poor prognostic markers except liver herniation with thorax is a classical poor prognostic sign. Associated malformations, particularly cardiac, have poor prognosis. Any herniation bilateral is definitely a poor prognostic sign. Lung to head ratio of more than 1 is usually a good, not a poor prognostic sign. Less than 1, where lung size is quite less compared to head, that is a poor prognostic sign. The answer here is LHR more than 1. The correct answer is LHR less than 1. Yeah.
So next question is, when is the anogenital ratio abnormal? Right. So anogenital ratio is something that we do for all the babies who have a suspected abnormal, wherever you suspect disorders of sexual development, right? So it is the distance between anus and posterior foreshead divided by distance of anus from the base of clitoris, right? So anything more than 0.5 is an indicator for first trimester androgen exposure, right? So distance between anus and posterior foreshead divided by distance between anus and base of clitoris.
So whenever you see a newborn or in an infant, definitely open the diaper or pant and actually see the area. You might pick up many abnormalities. There is one most commonly ignored. So preterm neonate with 1025 grams is on 82 ml per kg per day of EBM. What is the GIR? Normally we calculate GIR on IV fluid, but here the question is on expressed breast milk. The answer is 4 milligram per kg per minute. Let's see how the answer is. So GIR calculation, we know volume per kg per day into dextrose percentage divided by 144. Here the volume was 80 ml per kg per day. Dextrose in mother's milk is classically around 7 gram per deciliter, same as in term formula, and preterm it's around 8.2 to 8.6. So if you calculate that, 80 into 7 divided by 144 comes to 4 milligram per kg per minute. The same baby, if baby was on preterm formula, probably he would have been on 6 milligram per kg per minute.
Last question is about RBSK, right? So it's a very old program now. It's been there for around 2 decades. So Rashtriya Bal Swasthya Karyakram is for child screening for which all problems? We know it is for defects. They look for diseases, they look for developmental delays, and they look for deficiencies, various vitamin deficiencies, right? So defects like neural tube defects, Down syndrome, cleft lip, cleft palate, club foot, etc. Deficiencies, diseases, and developmental delays, right? So these are 4 broad headings where the RBSK covers, right? So this you should all be aware of.
So we have come to the end of this session. Any questions from the participant side? You can either post in the chat box or